This is Alissa.
This is Caroline.
And this is Chelsea. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud medical surgical nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
All right. Well, welcome to another episode. We are all together. Very exciting to have Caroline and Chelsea here with me today. It's time to do a little catching up. What's new, ladies?
I just came back from a cruise. That was really nice. Topping the tan up, you know. Went to the Virgin Islands for the first time, and I've done that on a cruise ship. So that was a different itinerary. So that was fun. Tortola, British Virgin Islands, and St. Thomas in the US Virgin Islands. And both islands drive on the other side of the road, but the steering wheel is on the same side as a car in America. So it wouldn't be like me going back to England and driving with the steering wheel on the opposite side. It was very confusing. We didn't drive, needless to say.
Sounds like a mix. Yeah.
Yeah. So that's my major updates.
What about you, Chelsea? How are you doing?
Hey, so I don't think our listeners know, but September the 17th, 2021, I lost my grandmother. And then 6 months later, March the 29th, 2022, I lost my mother. So that's been really rough. Anyone dealing with grief and loss, I definitely would suggest getting a therapist. I have a very type A personality, and this loss has just really thrown me off. I think I've definitely been dealing with some complicated grief. I've had to be on medications for depression and anxiety. So that's been difficult. But anyone going through a hard time or going through grief, don't be ashamed to get help or to talk about it. Definitely give yourself a lot of grace. You'll have a lot of bad mental health days. Just hang in there and get help. Don't be afraid to say no and just give yourself time. I've been very fortunate to not have to work since March, which has been nice, trying to just get myself together. I go back to work tomorrow, actually. So it'll be interesting to see how things go. I'm definitely ready to not be at home every day.
Yeah, I bet.
On a brighter note, I've got a puppy. Her name is Ziggy, and she has really helped with everything.
Yeah.
She's a certified emotional support animal, so she hasn't gotten the specialized training she needs for that yet. But, if I want to take her to the grocery store with me, which I do often, I can. She's very sweet. She lets me pick her up and kiss her and such. So that's been that. So
I don't think any dogs need training. It's it's intrinsic. They just come ready-made with the emotional support, just because that's what they all seem to crave, especially if it's a rescue. So we're really sorry to hear all that. Very candid of you to say that it's so important to be able to speak up and feel comfortable speaking about grief. And like you said, to not say no. People, I think, are at a loss sometimes as to what they can do or say. And just sitting there and listening is enough in many cases, as long as you can be receptive of that. So I think it's really important that you can acknowledge that. And it's very healthy for you as well that you can acknowledge that. So
it's definitely okay to not be okay.
Yes, exactly.
Definitely.
Yes.
Yeah. And I commend you for being so transparent as you go through your struggles. That's one thing that I've always really admired about you, bringing that and doing your check-in on the show and being really vulnerable with us when you're doing that, because I think that really shows that human side of who we are when we're doing the podcast.
Yeah.
And I just really appreciate you being willing to share the vulnerability of what's going on for real behind the scenes, because I can relate to struggles, obviously not relating to the grieving process that you're going through, but I can relate to, struggling personally and having issues with anxiety and stuff like that I'm trying to work on my own. And you're leading the way of showing that vulnerability has always encouraged me to be more vulnerable about what I'm doing with my own struggle. So I appreciate that.
Thank you. That means so much. I definitely think with the pandemic these past 2-3 years, it's been rough mentally, I think, on everyone. Just having that cloud of unknown disease and death hanging over you constantly has, especially for nurses in healthcare. So
time is a great healer, but I don't know if that's entirely true. I think you deal with it in your own way, and you're going to find that things quite unexpectedly out of the blue trigger a feeling or an emotion or a memory. And that can be difficult more for other people, I think, to witness, especially if you break down and get emotional. But I think that's absolutely the healthiest way to be. You just don't want to keep everything internalized, because then that makes things even worse. So
exactly.
Yeah, I completely
we're
agree.
glad to see you back, and the best of luck back at work. You have a team around you there to support you as well, I'm sure.
Absolutely.
Yes.
Great.
Well,
That's great.
Caroline, don't you have newlyweds in your family too that you can tell us about? Didn't you just have a daughter get married?
They've been married, newlyweds, for almost 3 months. Loving life. My daughter has moved in to the house that her fiance owned prior to them getting married. They would desperately love to buy a house together, but there's another topic. The housing market is just crazy right now. And she said just the other day they made an offer on a house. They thought it was perfect, and it sold for $125,000 over the asking price. I'm like,
oh, wow.
My first house didn't cost $125,000. So they're just bunking down in this cute little townhome and just making a life together. So they're very happy. Yes, thank you for asking
really
about
cute.
them.
Any grandkids?
I don't think it's going to happen just yet, but
it's early.
yeah, I mean, eventually. That's right. We look forward to that day. What about you, though? What about your updates? What's going on in your world?
With that, can I?
Come on, no. Spill the beans. What's going on?
What is going on in my world? Well, like Chelsea, I have had some mental health issues that I'm working on, lots of anxiety. And I think it's all residual from the pandemic. I think it's really hard to go from having like very limited social interactions to like, poof, now everything's back to normal and let's all gather again. I've noticed a lot of heightened social anxiety for myself. So a lot of working on that, a lot of like working on my own mental health and putting a lot of effort into that. And then just trying to like, I don't know, figure out this new normal. A lot of camping trips planned with family. Used to be a big traveler. Can't quite get the family out of the state. When I say the family, I really mean my husband. Can't get my husband on an airplane just yet. He's not ready to commit. He's hearing too much of like travel debacles and canceled flights and all that.
There's a lot of that going on. Yeah.
I want to be a part of it. So we'll just be tourists in our own state for now and see what happens. Yeah.
All right. Well, now we're all caught up. Let's give the listeners something interesting to talk about. How about the unstable patient because of a GI bleed? As they say in the news world, if it bleeds, it leads. We stop everything. It catches our attention, and we have to deal with a potential life-threatening emergency. Who has been in that situation?
One of the things that pops out in my head with GI bleeds is, are they stable enough for the med-surg floor? Or do they need to be on intermediate unit or ICU?
Well.
More than 4 units in a 4-hour span, they need to be off my floor.
There you go. Couldn't agree more. Yep.
That's one of the biggest things that pops up in my head. Obviously, initiating your GI protocols, whether they'll be in a proton pump inhibitor, a PPI drip, routine CBCs, how many stools have they had, measuring the stools if you can, the whole nine. But the largest thing that sticks out in my head is, are they stable enough for my floor?
Yeah, for real. Volume depletion and then the potential for hypovolemic shock, of course, is what we're trying to prevent. That's where we're looking at extremities for good IVs to get a good large bore IV and some fluid to replace that volume. The frequent vitals, and of course, counting or measuring everything that comes out of the body, whether it's an upper GI or a lower GI. I mean, there's no way to sugarcoat this conversation. It's not pleasant. It's not pretty. And it's terrifying for our patient. We're supposed to be used to these body fluids, but for a patient who's vomiting what seems to be gallons and gallons of blood, I mean, it's a terrifying experience. And so to try and remain calm and keep everything under control is easier said than done. Alissa, what are your experiences with good old GI bleeds?
I think the thing that comes to mind for me is when you get your patient on the med-surg floor who is deemed, right, quote unquote, stable because the bleed's under control, they're on their PPI, and then you have to worry about the rebleed. I think that's really where my experience with the GI bleed comes in, is that monitoring for the rebleed and suddenly your vital signs are out of control again, and your patient is no longer seeming stable and they look like they're about to crash, and you're pretty much helpless. I mean, how do you apply pressure to the GI tract? Hold still, like, let me apply pressure. It's just, it is a scary experience, recognizing that your patient's rebleeding on an acute care floor. So I think that's really where my experience with the GI bleed comes in, is just that fear of like, oh my God, they're rebleeding. I don't know what to do, other than just like call all of those emergency resources, getting the surgery team back up there, calling that rapid response if that's what you need, or, what I mean? Whatever those resources, suction, if they're vomiting, like, got to clear that airway.
If we think about this from the initial onset, knowing what baseline is always important. Okay, where's the patient bleeding from? Are they bleeding? What's the patient telling us? Are they vomiting blood? Is it bright red? Is it coffee ground? Are they passing blood from the other end? How long has it been going on for? Are there any pain associated with it? Establishing baseline is always helpful, because then we can assess a deviation from that for sure. The body, being the wonderful organ that it is going to compensate for such a long time. And then almost within minutes, the patient can turn on a dime. And that's what makes them so unstable. And that's where good med-surg assessment skills come in, so that we can determine that the patient is not safe anymore, and we need to get them off the floor to a higher level. So those baseline vitals, baseline H&H, baseline PT-INR sometimes, and sending off specimens if it's not obvious enough to make sure what we're dealing with here. Abdominal assessment comes into play as well, of course. But I think in my many years of nursing, I only remember really 2 esophageal varices situations. I mean, you've got this poor patient projectile vomiting, and the blood, sadly, that you're cleaning up for weeks afterwards, the velocity of which this blood shoots across the floor. I mean, we can laugh now, but in the moment, it's like, holy cow. What do you think the estimated blood loss is, nurse? Well, that wall's bright red and it shouldn't be. And the one over there is bright red and that shouldn't be.
That one over there is still dripping. How do we count that?
It's a funny, not funny situation. It's very serious, especially for those of you that are listening that maybe are not as experienced as some of us, and you're as terrified as the poor patient. Think about the psychological support as well in these situations.
Yeah, I've had patients with esophageal varices, but they were at the grade where they don't burst. I was working with a travel nurse at my first job, like my initial job after I became a nurse. And he told us a story about a patient with esophageal varices that was nauseous. And these varices weren't stable. And he was just like, please don't throw up. Please don't throw up. Well, the patient threw up and proceeded to bleed out and die.
And it's a really good combination of a medical surgical nurse when we think about this, because you've got the medical component of someone bleeding and then the surgical intervention, and oftentimes the emergent surgical intervention. So it might be good just to review for a minute, what do you do when you've got 20 minutes literally to get somebody ready and down to the OR? All the niceties of that OR prep really have to come down to what is essential. And so from the physician perspective, the consent form is essential and the explanation is essential. And then from our perspective, getting the patient ready, making sure they're just wearing the gown and checking their wristband and not forgetting all along to keep reassuring. It's all very fast and very emergent and very hectic for sure. And then making sure that, of course, post-operatively, that the bleeding has stopped and we don't have any signs and symptoms of any more bleeding along the way.
One thing that's important to mention are alcoholic patients who have GI bleeds, esophageal varices that we don't know. If they're coming in for alcohol withdrawal and we don't know their medical history, they haven't had a workup for anything GI related, I know oftentimes they'll either refuse care, like, oh no, I don't want labs today, or we'll miss it, like we're not getting a CBC or anything like that. We're just doing our typical CWA. It's important to also notice status changes in those patients as well. What else could you be looking for? Do they have a history of esophageal varices and GI bleeds? Because it's definitely something that should be on your radar.
Medication reconciliation, of course, is going to help with that. If it's not the disease of alcoholism, maybe the patient takes aspirin or aspirin-based products for some other issue. A lot of patients get very confused as to how much is too much. And of course, aspirin, for the benefits of it, also is very much an irritant in the GI system. And that can cause the redness, excoriation, ulcerations that get huge and engorge with blood and then ultimately will perforate. And there we have another topic about whether we're talking about gastric or duodenal ulcers, because they can be very covert in their presentation until pop, they burst, and we've got blood, a lot of blood with the patient vomiting.
I also think focusing on patients who are anticoagulated, those anticoagulation schedules can be confusing for patients who are just starting out. How much warfarin am I supposed to take? How often do I have to go get my blood drawn for the INR? It's difficult to manage when you are just starting out or don't have a lot of knowledge about your anticoagulation schedule and the labs that follow that. I've definitely taken care of patients who are coming in for that.
Yeah, I think you actually bring up a really good just point in general of patient education. Like the symptoms that our patients are going to be experiencing, like fatigue because they're losing blood, they're going to be exhausted and they're not going to have the energy just to get up and go to the bathroom or walk the halls, and being able to speak to that and just being able to really educate our patient on what they're feeling and how it ties into and makes sense into what's normal with what's going on with theirs. They may be experiencing abdominal pain. Well, they could have an ulcer that's bleeding. Maybe they just had surgery and got a bunch of GI clips placed. And so they got a bunch of things clipped. And so that could be uncomfortable. So these patients are going to be experiencing pain. They're going to be experiencing fatigue and anemia and all of these things that we could really be educating to. And then, as you said, for disposition of going home, are they going to be on long-term anticoags and all those kinds of things where they have to do follow-up in labs? It's a lot of education that goes in with a GI bleed, because, this isn't a standard thing and patients don't really know what to expect when you go into it, and then what to expect in terms of how to manage it when you go home. So a focus on patient education is very important, I think, with this diagnosis.
So here's something for you guys here. Have you ever been in a situation where your patient's bleeding, their H&H is low, the med-surg response is, let's get an order for a type and cross and transfuse blood? What do you do with a patient population that cannot or choose not to receive blood transfusions? They will only receive blood from themselves. And of course, that takes planning and preparation. Either of you been in that situation, and how did you resolve that?
I've worked with nurses who have, and for the most part, it's a palliative approach, because bottom line is that they need blood.
Right.
I don't know Alissa, if you have any experience with that.
Yeah. One story actually comes to mind. It was a patient in that situation that did not take blood product from anybody. And if I remember correctly, it was a trauma patient who needed blood. And it was really sad. It was like a 3-week drawn out, sad demise, slowly watching them die. It's really sad.
It's very difficult because there is really a very easy fix to this, but then we also have to respect the wishes and the beliefs of our patients. But it creates a very big ethical dilemma when, as a med-surg nurse, it's like, this is the problem. We know how to fix this. What is the issue? You know? And of course, you have to respect their religious beliefs, their thoughts. Very awkward. You have to really put on your best professional face sometimes, because you really just want to say to these patients, we can make you well. Why do you have to do this to yourself? But then, of course, that's the understanding from where they're coming from, what their beliefs are, the provision for culturally competent care.
In that case, they're holding on to or clinging on to the hopes of the body's natural ability to replenish the red blood cell supply. It's really sad, because when your body's that depleted, you can't regenerate quickly enough to sustain life. I mean, that was ultimately the issue with that particular patient. It's really sad that we can see that in advance because of the science and the knowledge that we have on how quickly red blood cells regenerate versus how desperately somebody needs them. And we can see the writing on the wall and be like, gosh, at this rate, it would take this amount of time for them to generate enough blood cells for them to be sustainable with life. And your person doesn't have that much time. But you're right. We do have to provide that culturally competent care, in that we will respect their wishes. And this is the culture and the belief set that they have. And let them make those decisions. And they did. And we respected it. So.
Yeah. And in those situations, of course, it's always as difficult when someone does pass. We know what the fix could be. And if there are family or friends that also see the same thought process as the medical team, supporting them when they realize that this person didn't necessarily need to pass away. They would have just consented to some blood products and plasma to fix the immediate problem. Yeah.
But then that puts us in the position that we have to advocate for what the patient wanted,
of
right?
Course.
Regardless of what our personal thoughts were. That's if right. We're now having to have that conversation with a loved one or a friend.
Yeah.
We have to advocate, well, that their wish is.
That's their decision. That's right.
And we're going to respect that and blah, blah, blah. Yeah.
That's exactly. Right.
Yep. We're the patient advocate.
Anyone got any good transfusion reaction stories? Did you know blood is one of the most common treatments that we offer our patients? One of the highest likelihoods of a reaction, an allergic reaction, from good old breaking out in hives to airway obstruction and anaphylaxis. And that's never fun, is it?
Is your areas in the practice of pre-medicating to try and avoid that mild reaction? Because that's definitely something that's in practice at my facility.
Yes, definitely. Especially if someone's never had blood before. And if they do have a list of allergies 3 pages long, you're going to tread very carefully and make sure you can really truly stay with that patient during those first 15 minutes to see if anything's going to happen.
I've never actually experienced a patient that has had a transfusion reaction, but I have assisted nurses with patients who have had like chest pain, et cetera, during a transfusion reaction. And we called a rapid response. That was interesting. I have taken care of, I think, 1 or 2 sickle cell anemia patients who have highly specialized blood needs. Like they have all these additives and different things that need to be in the blood. And so it takes like an extra day for the blood to arrive, which is nerve-wracking because they're anemic and their H&H is like 6 something and they need this blood, but it's going to take some time to get to the hospital. That was a pretty interesting process and a lot of paperwork that goes into like getting that specialized blood.
Yeah, I've had similar experiences with that with patients that have like special antibodies in their blood and stuff like that. And then I've had patients that their blood has to be like heated. Like they can only have it if it's heated to a certain temperature to be infused and stuff like that. So I've definitely had some interesting like blood transfusion instructions.
Oh yeah,
for patients.
It's important to remember that blood is stored in a refrigerator at some sub-zero temperature. Yeah. It's cold, when you're carrying it back up from the blood bank, you almost put it close to your body to kind of get it up to body temperature because cold blood can trigger a response as well.
Yeah, it is cold.
Yeah. Blood warmers come to mind. Haven't used the blood warmer in a while, but there are blood warmers out there, of course, but you've got to be careful removing it from the fridge and the time frame. You've got about 30 minutes between carrying it and hanging it. Yeah.
Yeah. Well, most of the blood warmers in our practice area are like rapid infusers. So it'll warm it up and rapidly infuse it. Not appropriate for the med-surg area. So those are always really scary to use if you have those instructions that you need to infuse heated blood. Yeah. You're like, what's more important? It's warm or it's slow?
Right. Good points. Yes. Good point. Pick your poison. Yes.
Yeah. Pick your poison. I want to give it slow, but you tell me I have to give it warm and I can only give warm fast blood with this machine. Yeah. I've definitely been in that situation. So I think blood infusion in general, it's one of those like high risk and high frequency skills that we really have to like pay attention and notch in.
For sure. Yeah. Has anyone had patients over the years that are just simply terrified of blood? Have you ever worked with a healthcare provider? I mean, I had a nurse I worked with. She was frightened of needles. I'm like, you're in the wrong job here. I am sorry. She was terrified of needles. Wouldn't give a shot to a patient. Couldn't even put the needle on the syringe. I'm like, and you got through nursing school? But anyway.
How?
I know. That's my question. Why would you do that to yourself? She's like, well, I'm going to work in a doctor's office soon. I'm like, they don't use needles in doctor's offices? But I digress. Anyone had patients just absolutely terrified of the blood?
I've had patients that don't like the sight of blood, so I usually just position the IV pole behind them.
Yes, good tactic. Yes.
And like feed if it's appropriate. Like if they have a really good IV and if they're easy stick, kind of feed the IV around like the back of the bed so they won't see it.
Great tip. That's a great idea. Yeah. I don't think I've ever had someone that's entirely freaked out, but they all worry, of course, that, the blood is the blood safe? Has the blood been tested? I'm not going to get any diseases from this. And I think that's very much old school now. We can reassure our patients very, very confidently that blood is very well screened nowadays. I used to donate blood regularly in England, but because of that mad cow disease, I cannot donate blood now in the United States anymore, even though I've lived here almost 30 years. So blood is tested very, very stringently, for sure, even to this day. Yeah. And I haven't had those questions come. Maybe I should rephrase that. The patients who ask those questions, I think, have probably had experiences with transfusions back when they were less safe, or maybe were more aware of them when they were less safe. But now that we have such a strict screening process and cleaning process for blood transfusion, I find it less common of a question with younger patients, if that makes sense.
Well, that was a really interesting episode. I look forward to doing more clinical episodes with you guys.
Yes.
Yes. Roll the outro. We look forward to connecting with you all on our next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org. I'd also like to remind you to become a member or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review, tell us how we're doing, and recommend med-surg Moments wherever you get your podcasts to help us reach even more listeners. I also invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #med-surg-moments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Chelsea.
I'm Alissa.
And I'm Caroline. And always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that make a huge difference.